Hello, Dr. Williams.
How are you doing, Nurse Sharonda?
I'm doing wonderful. Welcome
And
to
it looks like that.
Hello. Okay. Well, thank you for joining me on my first episode. This is the first episode of my Sista RN show.
Thank you for having me, and congratulations
Thank
on the whole show and everything you're doing for us.
Thank you so much, okay?
You're welcome.
It's been 7 years since we've worked together.
It has, but it feels like it was yesterday, does it not?
It does feel like it was yesterday, yeah? All right, so first I want everyone to know that Dr. Williams is a trauma surgeon here at Howard University Hospital, and I was the ER nursing director. And so we had a working relationship that I believe was one of the best of my career. And so I wouldn't have it any other way than to have but Dr. Williams on my show here today. So again, thank you.
You're welcome.
And running a trauma center, we obviously here to talk about trauma.
And I'm ready.
And you ready. So tell us a little bit about yourself, Dr. Williams.
Well, I'm a graduate of Morehouse College. And I think that's really, for me, where you have to start, because that's where I came of age in terms of a sense of mission, a sense of commitment to our community and the work that I do. So if I didn't go into medicine, I would still be heavily mission-based with regards to my work. I went on to the University of Maryland School of Medicine, where I got my MD. And from there, went on to Detroit to train in actual general surgery and trauma at the Detroit Medical Center in Detroit, and really get some of the critical foundational training in trauma that would really excite me about the specialty and make me want to be a trauma surgeon. From there, I went to the Brigham and Women's Hospital in Boston, and that was certainly an exciting time in my life, filled with wonderful mentors that I still cherish today. And from there, went on to take my first job in trauma, actually in Louisiana, in Shreveport, Louisiana, in the post-Katrina era, where we were helping Louisiana figure out how they were going to manage their trauma system after the horrific devastation of Hurricane Katrina. I've gone from there to the University of Toledo Medical Center, where I've become a leader of that level 1 trauma center, and would have great success there, verifying that trauma center under the standards of the American College of Surgeons, and then be recruited here, coincidentally, by the same chair, Dr. Edward Eugene Cornwell, that recruited Dr. Fulham here, to be the trauma medical director of the Level 1 Trauma Center here at Howard. And so that kind of gives me a distinction of being the only person to verify both a majority institution as a Level 1 Trauma Center and a historically Black college and university. And that's something I'm very proud of.
Good job.
Well, thank
Great
you.
stuff.
Thank you.
Now, you have a military background?
I do.
So tell me a little bit more about your military background.
I do. I hold it close, but I do have a military background. I'm a colonel in the United States Army Reserves Medical Corps. And it's been my great distinction and honor to serve this nation in both Iraq, Operation Iraqi Freedom, and in Afghanistan, in Kandahar, Operation Freedom Sentinel. And that's been a wonderful joy to participate in those contingency operations in the service of our troops. I think the other excitement about my military service, if you will, has been this opportunity to bring the contributions of both the civilian sector to the military, and then the military sector to the civilian areas, and really get this great cross-fertilization of the things that I've learned in both areas. And so it's been hard work. It's been a labor of love, and I'm happy to say that it's been 21 years of service to the nation.
Thank you for your service to the nation.
It's been my pleasure. My pleasure.
Now, I read something about Harvard.
Yes.
So tell me more. What type of work have you done with Harvard?
Well, again, when I left Detroit, I did my fellowship at the Brigham and Women's Hospital, which is a teaching hospital of Harvard Medical School. I also trained in the T.H. Chan School of Public Health, though it wasn't called that at the time. It was the Harvard School of Public Health. And I did the Master's in Public Health in health policy and management there. And I think the one experience that was very exciting for me during that time period was to actually be a Mongan Commonwealth Fellow at Harvard School of Public Health. And that fellowship was dedicated to minority health and minority health policy. And so I could take a deeper dive into the public health arena and understand things like social determinants, how to get stakeholders on board, and really understand the environmental factors which play a role in how we live and experience life and how our healthcare is given to us in the community.
Which takes us to why we're here.
Yes.
So we definitely want to talk about trauma.
Absolutely.
And we want to talk about it in its physical aspect as well as mental, emotional, right? And then we want to kind of talk about unresolved trauma and how it manifests itself, right? So one thing that we do as trauma leaders, or one of our goals is to prevent injury, right? And to prevent violence. So when people think trauma, they think violence. Can you define trauma for us?
Oh, yes. And that's a great question. Of all the interviews that I've done about trauma and violence, you're the only person to answer me to actually define it. And you're right. When people think about trauma, they fundamentally think about violence. What I want to put forth to you today, Sharonda, is that trauma is a transfer of energy from one thing to another. And that transfer of energy causes a deleterious effect on the person who experiences it. So, yes, there could be someone shot by a bullet violently. That would be trauma. There could be someone stabbed, and that also would be trauma, and that also would be violence. There could be someone who was assaulted by even maybe their significant other. And yes, that would be trauma. There could be someone who was abused because of who they are in the society, whether it's gender, whether it's race, whether it's orientation, and that also would be trauma and violence. But I want to also remind all of us that the transfer of energy can also be emotional in the things that we say. It could be emotional in the way we even look at our fellow brother or sister while we're passing along the street or taking public transportation. It could be the glare we give somebody who we feel may have cut us off while we're driving. There's also a transfer of energy there that can leave an impression upon someone that is not the best impression. And so trauma is this transfer of energy. We mostly think of that as a kinetic energy. It can be emotional. It really can be emotional.
Yeah. That was some good shit.
It's only...
Because the thing about it is, I've been running, I run trauma. Like
Right.
I'm ER.
Sure.
Right? And I'm head of a trauma center in an emergency department. And I haven't seen trauma that way, the way that you just described it, right?
Right.
And so now that you describe it that way, when we think about working in the emergency department or working in the trauma department, experiencing other people's trauma is definitely trauma.
We are being traumatized
every day.
And we have to definitely know how to manage that.
Yeah.
We definitely have to know how to seek help when that is needed.
Yeah.
And it probably the reason why I am more likely to define trauma in that way is because I have been to war. I have seen trauma, experienced it firsthand, and understand that also plays a role, even though the energy that resulted in that trauma was not transferred upon me. Just witnessing what happened,
yes,
is also a form of trauma. And we now well know that one can have post-traumatic stress disorders from experiencing trauma, they don't have to necessarily be the direct victims of what occurred.
Yeah.
Yeah.
Yeah, and so when we're in these emergency departments and we're experiencing someone else's trauma, and then a lot of times we're so busy in the ER world, we don't have time to kind of take a mental break.
Yes.
One thing I know we can do is build that mental break into the process.
Yes.
Debriefing,
Absolutely.
to me, would be a form of or a way to help nurses cope with the trauma that they just experienced.
Yes.
Do you guys debrief? Do you debrief currently?
I don't usually debrief
Okay.
on the civilian side.
Okay.
On the military side, we do what's called after action review, which is a debriefing.
Yes.
And I can tell you that the power of that is not just in quality improvement of how we do healthcare better or how we take care of traumatized victims better. Mm-hmm. The power in after action review or debriefing can also be in a validation that you did see what you saw. Mm-hmm. And I experienced it the exact same way you experienced it. Mm-hmm. And so we kind of then enter into this process of sharing that experience and therefore diffusing it somewhat.
Yeah.
Yeah.
Yes. So I strongly believe in debriefing. As a leader of emergency, I would put that in my processes, and I would definitely want a physician kind of leading that campaign with the clinical team that experience it. I know personally that definitely have helped me in traumatic experiences where I felt like, where I didn't know, oh, did we do all we could?
Sure.
And then have that physician come in and take us through the assessment. I remember it like it was yesterday. It was a 3-month-old. And he basically explained to us that baby, he showed us the modeling. He just showed us, made us feel better, and that we had given all of our efforts, so I know that is helpful. I've also heard about mindless games after experiencing a traumatic experience, that would decrease the impact of the trauma that you're experiencing. Have you heard anything like that, or things that we can do in that moment if we don't have debriefing in place?
Right. So I haven't heard about mindless games, but it doesn't surprise me that would help to you to cope a little bit. Okay. Because part of what I have to do as I go through a long trauma night and do trauma after trauma after trauma is put the last thing behind me to look at the next thing that's right before me, because I can't be distracted with the new trauma thinking about what happened with the old trauma. No matter how tragic what happened was, that scenario has likely concluded and the new scenario demands my full attention. And so I think good trauma surgeons are able to enter into a zone of tremendous hyper focus where they're not focusing on anything but the patient and the scenario that is in front of them. Not everybody can kind of compartmentalize the experiences like that. Mm-hmm. But I think on the trauma side, particularly in the operating room, you have to be able to do that. One of the things that I talk to people about is, every day you need to be talking about 3 good things. The mind has a tremendous negative bias. Mm-hmm. So you remember the negative things the most easiest. And what you have to do is bring to the forefront of your mind the positive things that happened in that day. And why you are grateful for those positive things. Not just that they happen, but what specifically makes you grateful for those things. And I think that is a sort of anti-burnout exercise that's been well documented in the literature.
Yeah. All right, so that takes me to my next question. Back to trauma, which we're still on trauma. What role does the hospital and the emergency department have in the community with regards to trauma and trauma prevention?
Yeah, that's a brilliant question. We must fundamentally see ourselves, Sharonda, differently than the classic definitions. And that means this: if we're only as a hospital or emergency department here to take care of the victims, then we must rename ourselves of people who treat the victimized. I think it's my position, and certainly here at Howard University Hospital Level 1 Trauma Center, it is our mission to be a part fundamentally of the building of people in the community. So we're not just stitching up and sewing up people who have been victimized. We're also building up people long before they are victimized, giving them resilience. So in this trauma center, you will see things that occur that quite frankly don't occur anywhere else in the world. You will see in this trauma center micro-philanthropy to activities that occur in the community that build up our youth. Teaching them not only how to ride a bike, but teach them how to build that bike and what are the physics and mathematics that go along with a bicycle. Investing in computer labs during the pandemic so that kids have a place to be schooled at. Investing in after-school programs so that children have a choice other than the usual choices that wind them up in the usual places. You will see us celebrating people who have been former victims and who now choose to be victors over violence. We give out an award here called Victor Over Violence. These are individuals who've had the trauma and now become beacons of light for the community and choose to tell their stories in ways that illuminate both the tragedies of the violence, but also the victory that can be had by the human spirit who chooses to overcome and who does overcome. You will see us having engaged programs and partnering with churches, the district attorney's office, schools, so that we sit down and we actually engage young people about issues in conflict resolution. Why are they so angry? And if they are that angry, why do they feel that violence has to accompany their anger? Why is that a connection necessarily? So many people in the world every day are disappointed. So many people in the world every day experience anger and yet do not accompany that emotion with outward violence. Why is it that certain segments of our population feel that those two things have to be connected? Because they really don't. And I find, as a person who participates actively in these programs, that the knowledge that our children give us when we just sit down and talk to them is quite telling. They kind of tell you what's going on right out of their mouths. And they kind of give you, if you will, some roadmaps to how we may begin to walk our way out of this forest and really pave new roads for healing within our community. But those conversations need to be sponsored. They need to be ushered on by individuals who have firsthand knowledge of what happens when those conversations are not taking place, who see the devastation as it comes into the door and understands just the horrific toll it plays in our community.
Good stuff. That was good. All right. So can you tell me more? Dr. Fuller mentioned Stop the Bleed.
Yeah.
Can you tell me more about the Stop the Bleed campaign?
Oh, sure. It's the American College of Surgeons endorsed program that teaches individuals who may be unfortunately in the midst of a shooting event how to treat a person who may be bleeding from an extremity, how to hold pressure, how to pack the wound, how to put on a tourniquet, and how to call for help, and how exactly to do those things in the appropriate sequence. It comes from recommendations out of the Hartford Consensus Conference. that was put together after a school shooting. It's a valuable, simple application that you would think everybody could do, and with good training, everybody at Howard University College of Medicine, all the students here get trained in it by the Trauma Center. With good training, you can hopefully mobilize these skills in spite of your fear and anxiety in the middle of these accidents and actually save a life. I like to look into the Stop the Bleed theme and even go further. I want to stop the bleed before there's bleeding. I want to go upstream. What I learned at Harvard School of Public Health is that when you want to solve problems in society, you've got to go far upstream from where those problems evolve and look to find the environmental, the social, the economic reasons for them and try to solve the problem as far upstream as you can possible. I think Stop the Bleed is necessary, but we also need to be stopping the bleed through our policies. And I think one of the things that Dr. Fulham mentioned quite correctly is this health in all policies approach. So communities need to be well lit. They need to have fixed sidewalks so that people can walk and feel safe. They need to be appropriately policed so that there are appropriate relationships between law enforcement and community. There needs to be a sense of trust in the education in the public schools so that teachers can talk to parents and parents can talk to teachers for early interventions. All of those upstream approaches stop the bleed. And each of them, if every trauma center in the country, every level one, that's over 200 of us, got together and just approached one aspect of the things that I've mentioned, we would be doing just fine. We'd be doing good.
What about our homeless?
Yeah.
Let's talk about our homeless.
Sure. People who have housing insecurity, certainly a very sensitive topic for me because I'm a veteran and a lot of our homeless have served our country. And so when we look at our homeless, sometimes we don't make that identification, that there's a significant amount of individuals who may fall under the title of homeless who are also veterans. They have given a significant amount to this country and to this democracy. And I think if you talk about it in that context, you engender a certain sympathy and a certain political will to do some tough things for that population, particularly when you talk about them here in the nation's capital, Washington, D.C. I think anytime individuals have housing insecurity, it puts them at greater risk to be exposed to violent elements that may be in the community. There's also a big percentage of homeless individuals who are also suffering from mental illness. And it's not just the mental illness. It is a mental illness that is not effectively or not being appropriately treated. And when we think about that, the tendency sometimes is to blame that back on the homeless individual and not realize those upstream factors. This nation has decreased its number of psychiatric beds in hospitals over the last decades. And so our ability to appropriately care for the people with mental illness may be probably at its lowest point, and we're not effectively resourcing the inpatient treatment side so that we don't get so many people with non-managed disease in a homeless capacity. But I do think what we know when we look at emergency rooms is that there are a small percentage of the population who generally account for a large percentage of the care. So when you talk about ED recidivism, when you talk about the numbers of visits per month, That's really reflective of a very small percent of the total population that ED is serving. And if you look in the literature, the evidence-based literature, you will see that approaches that focuses on that small, narrow cohort of patients are very effective. And what do? Intensive social work, placement of these individuals into secure housing situations or group homes, addressing the mental illness. A lot of this is done, by the way, through VA and veterans benefits that these individuals have that no one has ever known that they've had and never tapped into. These are not uninsured individuals by and large. The data would suggest that somewhere between 20-30% of these individuals have a service record, and with that service record have some sort of benefits.
Yeah, so we have to put more programs together where we can just ask the homeless and get their information.
That actually programs that identify them upon entry into the ED and appropriately then have resources around them to actually appropriately get them housed and cared for. There are our nation's veterans. There are programs that can benefit them greatly in terms of fixing their housing insecurity one time.
Yeah.
So the upstream policy issues, even if you solve them today, a lot of times the results from that will not occur immediately. It takes about 5 to 7 years, which is why there's some hesitance politically to solve those issues, because in a term of a politician, they may not see the results, particularly when you talk about education.
Right.
And so we have to work there, and we have to concomitantly work right where we are, down in the mess, right?
Yes.
And that's sometimes the uncomfortable work, because we're stitching up, sewing up, and dealing with the people who are acutely injured. At the same time, we're dealing with the families that are impacted by that, the unbelievable grief that they are suffering. At the same time, we are almost overly anxious about what's going to happen next. And we don't even admit it. Right? We saw what happened yesterday. We're like, okay, it's good weather outside. What's going to happen today?
Yeah.
That's a sort of interesting foreboding or feeling to have, right? And so what I would recommend is that for those individuals who have been injured already, we have hospital-based violence interventions, or what we call VIP programs, right? So the hospital-based violence intervention program, hence the VIP, really works with those individuals through their recovery to solve some problems that we could predict. PTSD, issues with going back to work and adjusting and getting them, as Dr. Fulham pointed out, re-socialized. That's a process with its resource needs in and of itself. And then you got the individuals who are in the community who are likely to be the population at risk to be injured. And then how do you kind of work with them to lower their injury risk? And so you talked about the children and the essays that you all doing. We here at Howard University Hospital we've adopted a middle school class from all the way through middle school. We took them to see Black Panther, the Wakanda movie, and we had them write essays about what did they experience and what did they see, the good, the bad, the ugly, and then use that as a platform to talk about conflict resolution. If you remember the last movie, there's a lot of deep themes that are going through that movie. The princess is dealing with the death of T'Challa. She's had death in her family, and that has been traumatizing. The mother, the queen, is dealing with the death of her son, and then a new trauma comes right on top of that. Her daughter is abducted, and then there's this big conflict between the people of Wakanda and other individuals that beneath the sea. But in the end, there is a resolution that comes in the midst of the conflict, right? What is it that, as we're fighting and we're at our maddest points, why are they able to come to a resolution? Well, quite frankly, when one watches the movie, someone has to see the fruitlessness of the pathway that they're both traveling. And someone has to concede the issue and be willing to listen and be willing to compromise and be willing to agree on some things. And so I like the movie because in the midst of conflict, we get to a resolution. And I think if we can teach our children who are out there looking at everything we do and soaking it in like a sponge, right? On the international level, I don't need to say more. On the national level, if we can teach them that for all of the appearing benefits, there are two conflicts. There is so much more in the resolution, in the nonviolent pathway that King talked about. If we can open their minds to that possibility, I think that's a huge first step. Keep in mind, in most of our children's elementary schools, there are no anti-violence curriculums. Think about it. We're not teaching how to live a conflict-free life to our children, and yet the politicians and we the adults are saying to ourselves, what can we do to stop the violence? Well, how about when people are learning their ABCs and when people are learning the basics in school, we teach them how to live in love with their neighbors? Is that so controversial? Is that so harmful in a democracy? Or could that actually be in many ways helpful? When I think back to my curriculum and all the content that I enjoyed in school and really gravitate to, a lot of it was about war, Civil War, World War I, World War II. And I'm not saying that it's not important to learn that. There are lessons in that need to be learned. But I would have loved to have had a curriculum presented to me, about anti-violence or a peaceful life and why those things are important or what the benefits are from those things. I think that, when you look at some of the curriculums that have been rolled out in schools and you look at the data, what do the data say? The data says that boys who are exposed to that type of curriculum, have less days absent from school. They have less time in terms of total punitive days. Their grades go up. Haven't had the same kind of results for our girls, but certainly we have seen dramatic results for our boys. And so I think we really have got to move toward an anti-violence curriculum in all of our public schools. That curriculum needs to be reinforced, as Dr. Terrence Fulham mentioned, in our faith communities. That curriculum has to be reinforced in what our kids watch on TV. We actually need people to produce anti-violent conflict resolution material that can be distributed on Netflix, Amazon, and Hulu, right along with White House Down and all the other action thrillers where, you have all of the various things being done. We need desperately content that is directed at children that really opens their minds and broadens their imagination to what the world can be like when there are peaceful means brought to bear, okay, on a day in and day out basis. And so I think that's the big solution, right? Is how we learn to live together peacefully and undo probably some of our other learning. Samuel Clemens said that most of education is unlearning what he had already learned that was false. And so we need to unlearn some things and go back and learn some new things that are truer than the things that we thought we knew.
So with that being said, I have been, again, in the inner city in Chattanooga, Tennessee. And so me being safe is a priority, right?
Yeah.
And so I know everybody's toting a gun, right? And I understand the dangers, but I can't be afraid of the community that I grew up in.
Sure.
So, and this is not a result of, but I also live in an area where the Confederate cemetery is across the street. So I said that to say, I think it's important that I am a gun carrying person, right? Or that I'm able to protect myself, especially with everything that's going on in our country. So with that being said, well, how do you feel? You know, there's people on the fence about whether you should carry a gun or not, and gun safety. I think gun safety is key. But what advice do you have for me toting a gun?
I think that your personal decision to own a firearm, which is your constitutional right, and to carry it as a form of your personal safety is a personal decision. I have full confidence, Sharonda, that when we sit down 5 years from now, even though you have made the personal decision to carry a firearm, that in 5 years you will not have intentionally killed anyone. Because so much of what is occurring when we talk about violence, particularly interpersonal violence, particularly violence in the inner city, goes beyond the possession of a gun. Okay? It really gets to competing over small amounts of resources. It really gets into harboring a vengeance because of something that has been done previously. Most of the victims of violence that I care for and I see, it's not because someone was shot during an act of self-defense or trying to defend themselves. That's not what I see. What I see are individuals who are either not participating and they are victims, what we would call in the military collateral damage to something else that was going on, that was interpersonal violence. I see a lot of individuals who are deeply involved personally with individuals who are violent. And so interpersonal or intimate partner violence, where we have women who are pregnant being shot, we have women who are pregnant being pushed down steps, we have women who are pregnant being violated in all kinds of ways. We have members of the LGBTQIA community who are being assaulted based on nothing more than who they are. These are crimes or violence that is being perpetuated out of people who are displaying hatred and who do not have a type of optimal humanity that will allow for the greater consideration of other people's humanity. And so I will often say, you can take all the guns away. You can limit the gun supply. If the heart or the humaneness of society is not dramatically increased, people will just stab one another. And if you take all the knives away, they'll just beat one another, right? Or throw rocks. The act of violence against another individual is not predicated on a gun. The thing that is important and material about the gun is that the kinetic energy that is transferred when the gun is used is often significantly more, and therefore lives are threatened. That's what's significant about guns. And so you say, well, Mallory, are you saying that we shouldn't be focused on guns? No, I didn't say that. What I clearly said was, I don't believe your possession of a gun will lead to an intentional death, because I know you and your humanity.
Yeah.
Right. As it relates to guns, I think that it's just as simple. We all agree as Americans, and as, in fact, this is an international community thing. We all agree when we get on an airplane that for the safety of everyone, for the safety of the pilots, for the safety of everyone on the plane, the stewardess, that we will agree not to do certain things. We won't smoke. Okay. We won't carry a firearm. Okay. We will adhere to the flight instructions as delivered by the crew. We agree to do that so that we all can be safe. So there are spaces where we need to enter into a communal contract with one another to be without weapons. Well, what are those spaces? Well, probably school zones, public places where there's really no apparent need to defend yourself because there are already police officers or law enforcement people there. Probably the floor of the Congress is one of those places where we don't need a weapon. Probably when we're voting, probably when we are attending church or mass and getting communion, we probably don't need a weapon at that time. And probably when we're being cared for in a hospital, we don't need.
We take away a lot of weapons in the hospital.
Right. We probably don't need a weapon at that time.
And everything in the hospital.
And so there are probably some gun-free, weapon-free zones that reasonable people, just like on an airplane, can agree in these spaces for the safety of everyone, we will abstain from having or carrying firearms or other weapons. And I think I have great faith in this country. Obviously, I've defended it for 21 years. I think we can come to those agreements, and I don't think that that's a matter of politics. That's a matter of common sense and just looking at our human experiences and saying that's probably what's best for us all.
Well, that was good stuff. That's what I want to know. People giving me really a hard time for I joined the gun club. And I joined because I wanted to be safe. I wanted to carry a gun and I wanted to be safe. Right? I want to know how to use it. I want to know how to stop, drop, and roll with it.
Yeah.
The whole nine. It's been a good time.
Well, listen, let me tell you a story.
Okay.
My godmother, who's a pediatrician, and her sister did the same thing for the same reasons.
Yeah.
They were the same individuals that were having knockdown, drag out arguments with me about whether someone should own a gun. And, I listened to them with one ear. But they came to the same conclusion that you came to, and they were going to the range and they were shooting. And it just surprised me. And then I looked up the data and it said African American women were some of the fastest demographic of gun owners in the country in terms of
our groups
during the pandemic. And so what I would say is that that's probably very little wrong with that. When we talk about gun deaths in this country, what most people will never realize is that 75% or higher of those deaths are suicides.
Suicide.
Okay? They're suicides, right? And what we found is that red flag laws that enable me as your friend to petition our common government to confiscate your weapons until you are found to be mentally prepared to own them and possess them. If I sense in you something is wrong, have saved lives. The horrific mass shootings that we see publicized on TV over and over again represent less than 1% of gun shootings. The urban violence that we see in major metropolitan cities, okay, again, still not as much as suicides, okay? And so when we talk about gun control policy, if we look at suicides, and most of those individuals are law-abiding gun owners, then controlling the amount of guns is really probably not going to get at that larger segment of gun deaths. Now, where we need to control access to guns is amongst individuals who should not, by law, be allowed to have a gun. Therefore, they are not purchasing their guns lawfully. Or if they are purchasing them lawfully, it is because someone has not done the appropriate checks with relationship to their background, or they are getting their weapons through what we call straw purchases. Okay.
What's a straw purchase?
And so you have someone else buying the weapon, okay, in the name of someone else who's going to really be the owner.
Okay.
And so when you look at Maryland or DC that has strong gun laws, what we see is that we still have gun deaths or homicide rates that are high because the areas that are around us are usually less well regulated, meaning Virginia. You can say the same thing in Chicago, and you would be talking about the areas around that city, less well regulated, Indiana, etc. And so people just go outside the city, get the guns, gun shows, etc., and then come back in. Very, very difficult to control. You see the same thing in New York, and in fact, along the entire Eastern Seaboard. And so some people will say, well, we need to close these loopholes and get rid of this aspect and get rid of that aspect. And I think most law-abiding gun owners, clearly me, are clearly in favor of common sense gun laws. Things that just make sense to everybody, right? But I tell you, the more I look at this, the more I study it academically, the more I see it as a trauma surgeon, the more I'm convinced that we've got to begin to operationalize how we fundamentally view each other's humanity. That starts at that's upstream. That starts at a much younger age. Okay, that demands a more long-range, tedious approach to the subject matter than perhaps many are willing to commit at this time, but it is the only way out. And so the question is, what do you do when the only way out of a problem is a hard one? You got to take the hard road, right? And that hard road is, how we value life, not just as it relates to a baby that's in a mommy's womb, but long after that baby has been delivered and is in the world. That proposition of valuation is what we got to really wrestle with and deal with. Yeah.
Well, thank you, Dr. Williams.
It's my pleasure.
Thank you. That was wonderful.